Let's begin. Let's begin our assembly today with Furqan Al-Fatiha. Before we start our CME today, I would like to remind the participant to turn off your microphone during the talk and don't forget to register in I-Attend for attendance. For medical practitioner, kindly fill in the Google form for CPD point. Google form link will be given in the chat later. Without further ado, I would like to invite Assistant Prof. Dr. Nur Ain Rabai from Department of Radiology, Sultan Ahmad Shah Medical Center to give her talk with a title, Basic Radiation Protection in Healthcare Workers. Tafadhol, Doctor.
I'd like to share my slide first. Okay. Can you see my slide? Can you see my slide? Can anyone answer me? Can you see my slide?
Yes, we can.
Can, Doctor.
Okay. Okay. Auzubillahi minasyaitonirrajim. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Allahumma salli ala sayidina Muhammad wa ala alihi washabihi ajmain. Assalamualaikum warahmatullahi taala wabarakatuh. Thank you for the moderator and all the participants for today's morning sessions. So as you all know, my topic today is about the radiation protection in healthcare worker. So I hope at the end of this sharing session, all the audience, all the participants can get some benefit from this sharing session, and it can then you may apply this in your daily routine, inshallah. So I would like there are a few outlines that I'm going to highlight on today's sharing sessions. I'm going to talk. So I'm going to talk about the rationale of radiation protection in medicines, why the radiation protection is really important for healthcare workers. Next is I'm going to talk a little bit about the rules and the regulations that control the worker and the activities involving the ionizing radiations in a medical field. We'll touch a little bit on the source of radiation protection and the principle of radiation protections, how the radiation dose should be monitored, and what is the best practice for the healthcare worker. Okay, so let me begin by sharing the report by the answer on 2000s. So basically we receive a radiation exposure from two types of source, either from the natural source or from the man-made source. So natural source such as radon from the building, food consumption, earth, and also from the cosmic ray. So while the human activity considered as a man-made source, such as medical activities. So also, answer reported that medical exposure contribute the highest radiation exposure received by human by 41%. So this includes the activity from the diagnostic imaging and also from the therapeutic. Answer reported on 2008 that they estimate about 4 billion X-ray examinations done per year worldwide. So in Malaysia, if you look in more focusing in Malaysia, there are about 700,000 of X-ray examination were performed in 2014. This was reported by Ministry of Health on 2014. So this statistic, including the non-clinical indications such as pre-employment, post-employment, and also insurance life. So I am believe that because of our current pandemic and the situation which is COVID-19, so number of examination, especially in X-ray examination, is increased. So therefore, the increased number of examination conducted present a challenge to ensure the appropriate radiation protection implements by the medical staff. So this statistic I borrow from the Bushberg, showing the comparison on statistic of medical exposure of patient at the early 1980s and 2006. If you look at the early 90s, most of the activities performed in general radiography, but at 2006, the CT examinations become the majority examinations. So this show that the general radiography is not the main radiation exposure received by the patients. So next we look to the statistic provided on the research that was published last year on 2020. So the number of patients undergoing CT examinations at 4 regions in USA involve 324 number of the hospitals. So the total number of CT examination that was conducted at these hospitals, more than 2 million examinations were performed. So the reason most of this study highlighted the statistic on the CT examination because they are concerning on the possibility of the cumulative effective dose received by the patients that may affect their quality of life in the future. So increasing number of the examinations performed will increase the radiation exposure to the patient, and at the end of the practice, it may increase the possibility for the healthcare worker to receive the unnecessary radiations. So the rapid development and trends in medical imaging increase a concern on the safety of the worker. So a few decades before, when we talk about the X-ray imaging or we talk about X-ray examinations, okay, we only perform the examination at the Department of the Radiology. But with the improvement, the technology, and the needs of the imaging itself, it has expanded beyond the radiology departments. So some of instrument or some of the equipment have been installed outside from the radiology department, such as C-arm, they also installed in OT and also certain department. Okay, other modalities such as cone beam CT that used for dental practice also has been applied and used widely as an additional to the traditional dental radiography. So other than that is a bone mineral densitometer, BMD, they also widely used in other departments. So this equipment installed in this clinic for better patient flow and comfort. So if you look to SUSMEC itself, there are few modalities that were installed outside the Department of Radiology, okay, such as we install it in DR at the ED, OT, pen clinic, and also in CAT lab. So thus, the need of knowledge on the radiation protection currently is not limited to the radiology staff only, but it has expanded to the all healthcare workers. Okay, in Malaysia, the activities of the ionizing and non-ionizing activity was controlled under Atomic Energy Licensing Act 1984, or also some called Act 3 or 4. This act was gazetted on 1984 with the intention to ensure the safe use of ionizing radiation in medical and non-medical fields. The hazard associated with the application of radiations are minimized and within the acceptable levels. There is no misuse of any radioactive materials, nuclear material, prescribed substances, or irradiation operated in relation to the prohibition stated in the Act. Under the Act of 3 or 4, there are few subsidiary regulations that control the specific activities such as Radiation Protection Licensing Regulation 1986 that are more focusing on the licensings, the Atomic Energy Licensing, Basic Safety Radiation Protection Regulation 2010, Radiation Protection Transport Regulation 1989, Radiation Protection Radioactive Waste Management Regulation 2011. So generally, exposure can be classified into three types: okay, occupational exposure, medical exposure of patient, and also public exposure. So occupational exposure is the radiation that is received by the worker as a result of their work. So medical exposure is the result from the medical activities with the intention for diagnosis or the treatments, voluntary help in the support, comfort patient, and also due to the biomedical research volunteer. So the next is the public exposure, is the exposure that results due to the activity other than occupational and medical activities. So this is including the background radiations. So the radiation from one X-ray room can come either from the primary radiation, scattered radiation, and also leakage radiation. The radiation came out from the beam here, we call it a primary radiations. So this is contributing most to the patient dose. So for the healthcare worker, most of radiations are received as a result from the scattered radiations. So when the radiations reach the patients, some of the radiation may scatter and reflect back to the surroundings. So this is what we call as a scattered radiations. So there is also possibility for the radiation to emit from the X-ray tube except for the useful beam. So this is what we call as a leakage radiations. So this leakage radiation is measurable and should not exceed 1 milligram per hour at a distance of 1 meter. So this leakage radiation usually we are measuring every year. We are measuring every year during a QA and QC procedure. So the next is we are going to talk about the principle of radiation protections based on the ICRP 2007. So based on the principle that was recommended by ICRP, there are three principles that is very important as the healthcare worker to implement on their daily routines. So the first one is the justifications. So any practice involving exposure should be justified. So they have to justify that the procedure will give more benefit compared to the risk if their activity or the examination is not conducted. So no practice involving exposure to radiation should be adopted unless it produces sufficient benefits. The second principle is about the optimizations. So under optimization, there is a ALARA principle, which is as low as a reasonable achievable. And the third one is the dose limitations. It is the exposure of the individual will be subjected to dose limit to ensure that there is no individual exposed to the radiation risks that are judged to be unacceptable. So as mentioned before, under optimizations, we have a ALARA principle, which is as low as reasonable achievable principles. So under ALARA, we have a 3 mantra of radiation safety that is very important to be implemented in our daily routine, which are time, distance, and also shieldings. So the time here refers to the length exposure to the radiations. So the shortest time exposed to radiations, less amount of radiation received. So the second one is the distance, refer to the physical space between the person and the radiation source. So the largest distance from the radiation source, lesser amount of your body exposed to the radiations. Increasing your distance from the source is the best things that you should do based on the principles of the inverse square law. So based on the inverse square law principle, if you double the distance with the source, you will decrease the radiation dose up to 4. The next is the shielding that refer to the material that can attenuate or that can reduce, that it can decrease the amount of ionizing radiation reaching a person. So example of the shielding here is a lead aprons and etc. So, but remember that the shielding itself will not provide an optimum protection if the user or the healthcare worker is not wear it properly. So under dose limitation, we talked just now, we have a dose limit. So under Act 304, Basic Safety Radiation Protection Regulation 2010, they also state state on a dose limitation for occupational and the public. So it is allowable to occupational worker to receive maximum dose up to 20 millisievert per year with annual equivalent dose to the lungs, skins, and hands feet is not more than 150 millisievert and 500 millisievert per year. This is for occupationals. So we also have international dose limit that is published, that is recommended by the ICRP. So ICRP also published a recommendation of the dose limit for the occupational worker and a public. So the dose limit for the occupational that was recommended by ICRP is similar with the BSRP with 20 millisievert per year, average over defined period of 5 years, which means in 20 millisievert per year, in average of 5 years, no single year exceed 50 millisievert per year. But on 2012, the ICRP introduced a new annual dose annual equivalent dose limit for length of eyes. So they reduced the maximum limit from 150 to 20 millisievert per year. Okay, this is due to the concern of the prevention of cataract with the assumption of nominal threshold at 0.5 gray. So I am happy to share with you all that with the all healthcare workers here with these latest applications. So I'm not sure if you are aware about this, but this is the new app that was developed for you to estimate your lens dose. It is developed by, I think it's a physicist that was developed this because of concern of the eye dose received by the healthcare workers. So this app is very useful for learning, education, and also awareness on the eye dose and the radiation protection for healthcare workers. So the best thing about this app, this eye radiation dose, is it's a free and available to be downloaded from the Apple Store and Google Play Store. So you just need to key in the details needed and they will calculate the dose estimated for the lens. So this is very useful for whoever that involved with interventional radiology, for interventional radiology. Okay, we talk about the dose limit of the occupational, we talk about the public, and how about the patients? So actually, the patient doesn't have limit. So there is no dose limit because due to the reason of their medical exposure. But we have a diagnostic reference level, which is DRL, that will monitor and control the dose received by the patient for specific procedures. So the important things here to ensure the important thing to ensure the safety of the patient, we back to the three principles that was recommended by ICRP. They are justification and optimization. The workspace was classified in radiology. We classify our workplace based on the nature of use of radiation source, estimated annual doses, hazard of contamination, and the nature of required protection and safety procedures. So when we enter the radiology department, we are easily acknowledged when we are easily acknowledge this workplace when we're reaching the radiation area by looking at this warning symbol. So if the worker who work at the area that may exceed 3/10 or 6 millisieverts per year, from the annual maximum permissible doses for exposure worker, the area will be classified as a control area. So in this area, specific procedure measurement and safety provision are required for control normal exposure or prevent the spread of the contaminations. So no person should enter this area, which is control area, unless he was assigned to the area or has been authorized to enter the area. The area where there is a possibility of exposure of staff receive more than 1 millisievert, which is more than annual dose limit received by the public, it will classify as a supervised area. So in this area, no specific protection and safety required, but the occupational exposure conditions are kept under review. So the last is a work area that was classified as a clean area where the annual dose received by the worker who work in this area is not exceed the dose limit for a member of the public. So when we enter and when we entering or we involving with the radiation area, special radiation protection equipment are required. It is included glass, thyroid collar, lead aprons, and also personal dosimeter. So based on basic safety standard, the worker should be provided with a suitable and adequate personal protection equipment with meet any relevant regulation or the standard. Specific procedure required specific requirement of the protective attire. So for example, for procedure that operates up to 100 kV, the protective apron should be at least 0.25 millimeter plumber equivalence. So 0.25 mm plumber equivalent is enough for procedure that but for the procedure that operate up to 100 kV, 0.35 plumber equivalent is required. So interventional radiology staff should use 0.5 mm plumber equivalence because of the high level of the scattered radiations. A radiation protection equipment cannot provide the optimal shielding to the user if the user itself doesn't give a proper maintenance to it. So this is like win-win situation. If you take care of your radiation protective equipment carefully, so it will provide an optimal service to to protect from the radiations. So how to maintain your radiation protection equipments? So this is a few recommendations that you can use, where never immerse in water, clean regularly, but never use product that contain bleach, or use it on the machine launder, autoclave, or dry cleans. Avoid cracking the protective material by never fall or crease when stored. This because there is a possibility for your radiation protective equipment to be cracked. Will be cracked, and it will reduce the useful lifespan of the apron. So never expose to extreme hot or cool temperature or to direct sunlight. And the best practice is to hang the apron on the designated area after every use. So this is an example when the apron sent to the cleaning service hospitals without appropriate instructions. So these aprons totally cannot be used anymore, and it is such a big waste to the hospital, because we know the protective apron is not cheap, and it's not cheap to get. And if you see only a small dirt on the apron, just wipe it with the tissue or the wet tissue. Okay, after a proper maintenance by the users, so the RPE, the radiation protective equipment, also has to go through the inspection annually, or whenever the user thinks it is necessary to the inspection. So if the user thinks their equipment have a crack or defect, they are allowed to send it, or they can request to send it for the inspections, and we will provide a report after inspection for your reference. So RPA should be inspected at least annually, or whenever user thinks it is necessary for inspections. So the RPE will be rejected or considered unsafe to be used if the sum defect is greater than 50 millimeters square, unless the defect is clearly not over a critical organs. And for the area at the back, it should be replaced only if the defect is greater than 670 millimeters squares. And for the thyroid shield and the gonad shield, the sum of defect exceed 11 millimeters square, which is equivalent to 3.8 millimeter diameter circular hole. So this is a criteria of rejection for the radiation protection equipment after the inspection. So if your radiation protection equipments under this criteria, we are recommend to replace with the new ones, and it's considered as not safe to be used. So this is example of the report after the inspections. So this is a report that mention the tested date, the method of the investigation, and also the status either the RPE is safe or unsafe to be used. So it also stated the recommendation date for the next inspection, which is usually we are recommended to check it annually. So whenever so we are going to provide this report after every inspection for your further reference. Okay, I talk about the radiation protective equipment, and I also talk about the protection for the radiations. So as a healthcare worker, it is impossible for us to avoid from the receiving the radiations. This is why we need a personal dosimeter to monitor the dose received. So when we are provided with the personal dosimeter, it is not a tool to protect from the radiations. So it is just a tool to measure the radiation without giving any protection from the radiation. So just bear in mind, the personal dosimeter doesn't protect you from the radiations. Okay, so for all all the worker who for who should get and who should not get a personal monitoring. So for all the worker who work in a controlled area, they are required to have their own personal dosimeter. But for the worker who are normally work in a supervised area or enter a controlled area occasionally, they are do not required to have one. So it is just enough for them to adapt and implement the principle of radiation protection that was discussed earlier, which is justification, um, those limitation and also optimization. They also should implement the ALARA principle, time, distance, and shieldings. There are type of radiation. There are few types of radiation monitoring device. So personal monitoring, we have TLD, we have OSL, RPL, and also pen dosimeter. For area monitoring, we have a servometer and also GM counter to monitor. So TLD, OSL, ring dosimeter is considered as a passive dosimetry because it doesn't provide the immediate reading to your user. Instead, the user need to send to the outsource for read out. So while for the pen dosimeter, servometer, and also for GM counter, it is considered as the active dosimeter because the contamination they appear immediately. Occupational dose limit has been established to ensure that the risks arising from the occupational exposure are minimal. So this is the reason why we introduced the radiation monitoring device to monitor and alert the radiation exposure. So for Basic Safety Radiation Protection Regulation 2010 recommended that every licensee should ensure that all the workers should not exceed the relevant dose limit. And the ICRP 2001 also state that high occupational recommend for the high occupational exposure in interventional radiology require to the use of reverse and adequate monitoring arrangement for the staff. So they are recommended for the staff at the interventional radiology department to develop a policy that the staff should wear two dosimeter. So they recommend to use two dosimeter to put it above the lead apron. The lead apron that will indicate the eye, the dose in the eye, and also under the apron. So as mentioned, it's recommended for the interventional radiologist to use two dosimeter because the intention that they will receive the highest radiation as a result of the scattered radiation from the patients. So this is where it should located under the aprons, and also above the apron, they should put on the neck. So I mentioned about the passive dosimeter where it doesn't provide a direct reading, so need to send to the outsource for read out. So our personal dosimeter OSL is one of the passive dosimeter. So we usually send it out for reading, and each time we receive the OSL for the next usage, it will come together with the report from the previous months. So on the report, you can see that there is a HP10 that indicate the dose equivalent in soft tissue at 10 mm depth that is considered as the effective dose. And also there is a HP 0.07 that indicate the dose to the skin and the extremities. So based on based on the regulations, the worker, the licensee should based on regulation, licensee should inform each worker their personal monitoring result and radiation exposure status not later than 14 days from the date of the licensee receive. So when the worker may receive the reading exposure more than 100 millisievert per year, which is very impossible to occur in our daily routines, employers should ensure that worker undergoes medical examination and investigation by approved registered medical practitioner. So this is we talk about the effective dose, the estimation of effective dose for the worker who have 1 dosimeter. So how about the worker who are provided with the 2 dosimeter? So this is how we calculate the effective dose calculation. So this is how we estimate. So we are going to consider the both personal dosimeter that is put under the apron and also over the aprons. So there is a study conducted in Spain on the habit of the specialists at the interventional radiation regarding the knowledge on the use of the personal dosimeter. So they come up with the result that 36% of the specialists acknowledge that they forgot to use their own personal dosimeter more than 7 days per month. So it is approximately 30% of their workload. And 50% of the radiologists do not use ring dosimeter regularly. So at the end of this, it is about the responsibility of the user. It is about the responsibility of the healthcare worker itself. And it's not, we are here. So this study is conducted in Spain. So how about the Malaysia? How about in SASMEC? Okay, how about our own practice? Are we really having a good habit or bad habits? So we are not here to blame or to say that you are practicing a bad habit or good habit. But this topic is quite interesting to be studied and explored, as the intention to increase the awareness of the radiation protection and the safety of the healthcare worker. So if one day there is a situation for the unusual reading by the personnel, so the investigation by the respective person should be started. So if the dose is on the alert levels, the worker will be notified regarding the reading for him or her to be alert on his or her current status. But when it reached a third quarter of the annual dose limit, which is 50 millisievert per year, okay, the investigation should be start immediately. So investigation will start with the check the validity of the readings. Okay, it will check either there is a wrong location, wrong ID, or the personnel or the user left the dosimeter under the direct beam. So if invalid reading is suspected, we are going to monitor the next monitoring period should be reviewed. But after investigations, then they found the dosimeter had been stored and worn correctly. So the training and education will be provided, and rotation or work schedule may be needed. For the next slide, I'm going to touch a little bit on the protections during mobile X-ray. So it is discouraged for the examination using mobile X-ray unless it is really necessary, where the patient is too ill to transfer to our departments, and the justifications for that patient was met. So when the justification was met and the procedure need to be conducted, so the patient exposed, so the distance between the patient exposed and the patient on the next bed should be at least 2 meters. So this is based on the principle inverse square law that mentioned before, where the largest distance between the source and the patient, the less amount of radiation exposed. So So within 2 meters of the patients, which is indicate the red color here. So no one should stay here, okay? And whoever who stand in this area required a lead apron as a protection. So when exposing to the ionizing radiation, there are two possible effects can happen, either deterministic effect and stochastic effect. So effect that can be seen after few weeks or few months of exposure is considered as the deterministic effect, and the effect that can only appear after a few months, 10 or 20 years, maybe it's considered as a stochastic effects. So this is an example of the hand of the early radiologist due to receive very high radiation dose. And each level of exposure give different effect on the human body. So example, so when body receive 50 rem, 55, 70 rems, so the person may feel nausea and may will vomit and may get hair loss. But the worst condition when they receive 1,000 rem for 1,000 rem, so they may result for internal bleeding or even death. So as a healthcare worker, or when we are a healthcare worker or we are colleague get pregnant, this is a few safety that we can apply. So the first thing is notify the employer in order that her working condition may be modified if necessary. But remember, the notification of the pregnant should not be considered as a reason to exclude a female worker from the work. But the worker need to adapt with the working condition in respect of an occupational exposure. So embryo and fetus have to be treated and affordable the same broad level protection as a member of the public. So it is recommended to establish a maternity policy. For example, where should the worker work? Okay, what is the procedure that can be attended, and etc. So how to estimate the fetus dose? So we will look back to the effective dose of the personal monitoring results that we get every month, and to be specifically estimate on the fetus dose, there is a conversion factor that can be applied that it will calculate can be used for calculations. So the estimation of the fetus dose only necessary if the fetus is in or near the primary beam. So as a healthcare worker, there are some questions that you should ask to yourself. Do you wear a lead apron? Do you wear a glove? Do you wear a thyroid shield? Do you wear an eye goggle? Do you use a minimal procedure time? Are you keep enough distance from the radiation source? Oh, and the last is, are you always wear your personal dosimeter during work? This is a few questions that you should ask to yourself as a healthcare worker, and to ensure that you are practicing the safe practice. So I come to my conclusion that answer reported that 80% of general and city radiographer did not reach measurable doses based on the source. So it is confirmed that the well shielding give well protection to the workers. Radiation protection standard recognize that it is impossible to eliminate all the radiation exposure, but they provide a system which is a three principle that are recommended to avoid unnecessary exposure and to keep the dose in the low dose range. So by limiting dose to the level below the thresholds, the determinative effects can be minimized. So if you are interested to learn more on the radiation protections and anything related to radiations, you can go through and search to bahagian kawal selia radiasi perubatan. They have a small column here which is pautan berguna, and there is many links that you can use for your own reference, such as they have KKM, AELB, Nuclear Malaysia, Radiology Malaysia, ANSWER, AAPM, ICRP, and etc. So you can go through and click whenever if you interested to learn more on this on this. So this is take-home notes. Radiation dose is adequately controlled by shielding, radiation monitoring instrument, and a protective attire. Occupational doses should be analyzed. High dose and outliers should be investigated. Protection equipment should be examined periodically and inspected visually for damage and defect. So the most important thing is speak up if there is a concern about the safety practices. If you as a healthcare worker think there is a practice, or you have any if you have any question, or there is something that you think that this practice is not correct, or you unsure about this practice, you have to speak up to your supervisor or your superior for them to highlight this issue. So please speak up whenever you think when you have any concern about the safety practices. So which one are you? Are you underprotected or are you overprotected? If you think you are underprotected, so improve your practice, improve your work routines. But if you think you are overprotected, should be good. This you should keep it on track. Okay. So before I end these sharing sessions, I would like to share on our upcoming events that will conducted by radiology departments. So we are going to conduct a radiology protection course for 1 day. It will conduct via Zoom platforms. Time and date will be announced later. So there are many things that will be shared by the expertise, especially in the practice during the pandemics. So therefore, I am here to invite and to take this opportunity to invite all the staff here to come and support our events. So all are welcome to join and can directly ask us for more informations. So I hope all can come and support our events. So by that, thank you. If you have any further question, you can drop me an email later. So thank you.
Thank you very much, Dr., for your interesting talk. Now we open the floor for Q&A session. If the audience doesn't have a microphone, you can type your question in the chat box.
Is there any questions? If no question, you also can drop me an email whenever you think you have if you think you have any question to ask me personally. Just drop me an email.
Dr., I think there's no question for time being. again, the audience can drop question to Dr. Norai at the email given. Okay, thank you again, Doctor, for your interesting talk. I would like to remind the participant to register attendance in iAttend and for medical practitioner to fill in the Google form through link given. We end our CME today with Tasbih Kafarah and Suratul As. With that, we end our CME today. Assalamualaikum warahmatullahi wabarakatuh.